This is where we give you that crucial deep knowledge you need, but without you having to sift through a dozen dense journal articles to get it.
Glad to be here.
Today, we're taking a journey into, well, what is often a very painful topic, chronic joint distress. But we're not just talking about general aches. We are going to dissect the pharmaceutical arsenals that are used against two fundamentally different enemies. On one side, you have rheumatoid arthritis,
Which is an autoimmune disorder,
and on the other, you have gout.
a metabolic disorder. And that contrast you just set up, that is everything. It's really the core of this whole deep dive.
Right.
If you're trying to get a quick handle on modern pharmacology for joint disease, you absolutely have to understand this distinction. The drugs for KI are all about systemic suppression, about, modifying the entire immune system.
Long game.
A very long game. Whereas the drugs for gout are much more like a two-phase military operation. First, a surgical strike against the inflammation.
Putting out the fire.
Putting out the fire, exactly. And that's followed by long-term metabolic maintenance.
Okay, so we've got a pretty comprehensive stack of source material today. It gets into not just the mechanisms of these, incredibly powerful drugs, but also the serious trade-off.
Oh, absolutely. The toxicity versus the efficacy. It's a constant balancing act that doctors and patients have to navigate every single day.
So our mission today is pretty simple then. We want to make sure you walk away understanding that critical strategic difference.
Right. One disease, RA, requires that long game we mentioned, using what are called disease-modifying anti-hemotic drugs, or DMARDs, to halt a rogue immune system.
And the other, gout, demands a totally different acute strategy for those crystal flare-ups.
Immediately followed by a chronic metabolic strategy to keep uric acid levels down. That distinction is really, it's the key to everything we're going to talk about today.
All right, let's unpack this. We're going to start with the long, complicated war against the body attacking itself. Rheumatoid arthritis.
Let's do it.
So when we talk about RA, we have to be really clear. We are not talking about simple wear and tear.
No, not
The source material is unequivocal. This is a systemic, chronic autoimmune disease. The body is literally turning on its own joints.
And that leads to this cascade of inflammation, the aggressive thickening of the joint lining, which has a technical name, synovial proliferation.
Okay.
And then eventually, the irreversible destruction of the articular cartilage.
It really is a self-destructive feedback loop then.
It truly is. The disease kicks off when the immune system, for reasons we don't fully understand, mistakenly creates these immune complexes. They usually involve IgM antibodies.
And these complexes are the trigger.
They're the trigger. They activate what's called the complement system. You can think of it as a cascade of proteins that's normally designed to fight infection, but here it just accelerates the damage.
And once that cascade starts, that's when the real chemical demolition crew gets called in, right?
Precisely. The activation of complement leads to this massive release of really powerful signaling proteins. We call them cytokines.
Cytokines.
And the main culprits in RA are tumor necrosis factor alpha, or TNF, and another one called interleukin-1, or IL-1.
So these are like the artillery commanders of the immune system.
That's a great way to think of it. They send out the distress calls.
And what happens when that distress call goes out inside a joint?
Well, they initiate a process called chemotaxis. It's basically a chemical signal that attracts huge numbers of white blood cells, specifically neutrophils, to rush into the joint space.
Okay.
And once they're there, these neutrophils release their payload. Incredibly powerful lysosomal enzymes.
And it's those enzymes that do the actual damage.
It's those enzymes that physically dissolve the cartilage and start to erode the bone. That's what leads to those classic permanent deformities you see in advanced RA.
And I imagine this is incredibly painful.
Oh, immensely. At the same time, you have prostaglandins PGs being generated, and they cause vasodilation, swelling, and, critically, that intense throbbing pain.
So this is not a mild inconvenience. This is a full-blown mechanical and chemical demolition process that is chronic and progressive.
It is progressive, and it is crippling. Now, RA can have periods of remission and then flare-ups, but the overall trend, if it's left untreated, is always downward.
And it has a preference for certain joints, right?
It does. It preferentially attacks multiple small joints, especially in the hands and feet, which is why preserving function is so crucial. If you don't slow the disease, you are guaranteeing deformity down the line.
So given those stakes guaranteed deformity, what are the immediate and the long-term goals of treatment?
The goals are really layered. First, you have to deal with the symptoms. The pain, the stiffness, the swelling. That's job number one.
Get the patient some relief.
Exactly. But second, and this is the paramount goal, you have to prevent the structural damage. You have to stop that cartilage damage and those bony erosions.
Which leads to the third goal, I assume, which is preserving function.
Preserving joint function and mobility. That's the ultimate aim.
The initial approach, though, it seems a little contradictory. You start with symptomatic relief, but that doesn't actually fix the core problem.
Correct. The very first thing a patient needs is comfort. So nonsteroidal anti-inflammatory drugs, NSAIDs, are the first-line agents for that symptomatic relief.
Okay.
They are powerful, they reduce inflammation and pain very effectively, but, and this is probably the most critical distinction you need to grasp in this whole section, NSAIDs do not change the course of the disease.
So they just mask the symptoms while the demolition continues underneath.
That's exactly, which is why the current clinical standard is what our sources call the DMARD mandate.
The DMARD mandate.
Yes. The mandate dictates that as soon as RA is confirmed, you have to introduce DMARDs, those disease-modifying anti-rheumatic drugs, and you have to introduce them early.
Even though they come with some serious risks.
Even though they carry the potential for serious adverse effects. The medical consensus is that the risk of guaranteed, permanent, crippling joint destruction from untreated RA, that risk far outweighs the immediate risks associated with these powerful suppressive drugs.
And the immune system is a tricky opponent, so one drug often isn't enough, right?
Absolutely. The immune system is clever. Individual DMARDs tend to lose their effectiveness over time. So in persistent or advanced cases, it's standard practice to use combination regimens, 2 or sometimes even 3 DMARDs at the same time, to maintain that suppression.
All right, so let's get into those non-biological DMARDs. This is really the foundation of treatment.
It is.
And the defining characteristic seems to be this slow action requirement. I mean, they're even sometimes called SARDs, slow-acting antirheumatic drugs. Why does it take months for these things to kick in?
Well, it takes months because they're fundamentally altering the immune response itself, not just blocking a pain signal. An NSAID can work in hours. A DMARD has to suppress the core rheumatoid process. That means downregulating cytokine production, slowing immune cell proliferation. That's a slow process. You need months of consistent treatment, 3, 4, sometimes even 6 months, before you see the full beneficial effect.
And the undisputed anchor of this entire strategy is methotrexate, or MTX.
MTX has absolutely revolutionized the treatment of RMAA. It's actually a dihydrofolate reductase inhibitor.
Which is a mechanism we usually associate with cancer treatment.
It is. We originally targeted it for rapidly dividing cancer cells. But in RA, at much, much lower doses, that same action translates into powerful immunosuppressant and anti-inflammatory effects. It inhibits cytokine production. It interferes with chemotaxis. It essentially puts the brakes on the proliferation of those damaging immune cells.
And it's the preferred initial choice because it's predictable and, well, for a DMARD, it's relatively fast-acting.
Right. Relative is the key word. Symptom relief can start in as little as 3 to 6 weeks, which, compared to some of the other DMARDs, is really quick. It offers a sustained, long-term response, and it's the pillar of pretty much every combination regimen used today.
Okay, but let's spend a serious moment on the potential dark side of MTX. The sources highlight a really counterintuitive risk that's related to its dosing schedule.
This is a critical insight for anyone trying to understand pharmacology. If you use MTX in short, high-dose bursts for cancer chemotherapy, you get certain toxicities, sure, but progressive liver damage isn't usually the main one.
Okay.
In RA, however, because the therapy is prolonged, we're talking years, sometimes a lifetime, with weekly dosing, there is a genuine risk of dose-dependent progressive liver damage, and that includes cirrhosis.
So the chronic low-dose exposure presents a risk that the acute high-dose exposure doesn't. That's fascinating.
It's a function of time and cumulative exposure. And because of this, stringent, regular monitoring of liver function is absolutely mandatory for these patients.
What other risks are we looking at?
The other significant risk mentioned is an increased incidence of chest infections, which, leads us directly to its contraindications.
And those contraindications are, they're non-negotiable, right?
Oh, completely. MTX is strictly forbidden in pregnancy or breastfeeding. It is a major teratogen.
Okay, what else?
It's also contraindicated if the patient has existing liver disease, an active infection, leukopenia, that's a low white blood cell count, or a peptic ulcer.
And on top of all that, you have to watch out for drug interactions that could turn a therapeutic dose into a toxic one.
Absolutely. This is another layer of complexity.
Yeah.
If a patient is also taking, say, probenecide, a drug we'll actually talk about later with gout, or even just high doses of aspirin,
Right.
both of those can increase MTS toxicity by messing with its excretion from the kidneys. And even a common antibiotic like trimethoprim can add to the inhibition of dihydrofolate reductase, which can significantly depress the bone marrow. You need a very detailed medication history before starting MTX.
So, moving on from MTX, what other immunosuppressants fill specific roles when MTX is either not enough or can't be used?
Azathioprine is a notable alternative. It's converted in the body to its active form, 6-mercaptopurine, which suppresses T cells and natural killer cells.
And what's its main use case?
It's often used for what's called its steroid-sparing effect, especially if the RA has significant systemic manifestations beyond just the joints.
But there's a catch.
There is. You cannot combine it with MTX.
And then we have the reserved, almost last-ditch drugs in this category.
Right. Drugs like cyclosporine, chlorambucil, and cyclophosphamide. These are highly toxic, and they are strictly reserved for those extremely severe, rare cases that are completely refractory to all the other safer DMARD combinations.
Okay, now let's look at the other immunomodulators, the next wave of non-biologicals. Some of these were famously repurposed from other uses.
Starting with sulfasalazine. It's often used as a second-line drug for milder RA or more and more in combination with MTX.
And do we know how it works?
The mechanism is still a bit obscure, honestly. We think the active component is the absorbed sulfapyridine part of the molecule. It might suppress things like superoxide radicals or cytokines.
And what's the key thing to monitor with this one?
The main patient management point here is the risk of neutropenia or thrombocytopenia, so low white blood cells or platelets, which demands regular blood count monitoring.
Then we have the antimalarials, hydroxychloroquine and chloroquine. These seem to be the ultimate low-risk, low-reward option.
That is the perfect description. They are the low-efficacy agents. They do not prevent the bony erosions.
But they're safer.
But their toxicity profile is low enough that they're reserved for milder, non-erosive disease. They're very slow, often needing 6 months to really show an effect.
But the unique toxicity here is quite specific, and it involves the eye.
Yes. This is a big one. The long-term toxicity is a result of the drug accumulating in melanin-containing tissue.
So the retina
And the cornea. This presents a real risk of serious, irreversible retinal damage. Hydroxychloroquine is preferred because this toxicity is less common and potentially reversible if caught early.
So anyone on this long-term needs to see an eye doctor regularly.
Absolutely. Careful, regular ophthalmological monitoring is mandatory. You have to make sure you're not saving a joint only to damage the patient's sight.
Next up, leflunomide. This one sounds like a high-efficacy alternative to MTX.
Its efficacy is comparable to MTX, and it works relatively fast with benefits seen in about 4 weeks.
But a different mechanism.
It inhibits an enzyme called dihydroorotate dehydrogenase, which effectively suppresses pyrimidine synthesis.
And pyrimidines are building blocks for DNA.
Exactly. And lymphocytes need a lot of pyrimidines to proliferate rapidly during an immune response. So this just puts a halt on their expansion.
So it's a good alternative to MTX, but you don't combine them.
No. Combining MTX and leflunomide dramatically increases the risk of liver toxicity. It's one or the other.
And finally, in this group, tofacitinib, a newer synthetic drug that targets an internal communication highway inside the cell.
Tofacitinib is a newer synthetic DMARD, and is approved for severe cases that haven't responded to MTs. It's what's called a JK3 and JK1 kinase inhibitor.
What is that? The JAK-STAT pathway.
The JAK-STAT signaling pathway is, essentially, it's the central command line that cells use to react to cytokines. Tofacitinib gets inside the cell and interferes with this pathway, blocking the messages that tell the immune cells to get inflamed and to proliferate. It's incredibly targeted.
But like the others, there's a crucial restriction on combinations. Why the hard stop on combining it with other immunosuppressants?
Because if you block this key internal communication pathway, you are globally suppressing the immune response. If you then add azathioprine or cyclosporine or any of the biological DMARDs we're about to discuss,
You're just stacking suppression on top of suppression.
you are. And you increase the patient's susceptibility to opportunistic infections, including the flaring up of latent tuberculosis, to an unacceptably high level.
So now we move to the most powerful, most expensive, and most targeted class of drugs, the biological agents.
The big guns.
These are complex, genetically engineered proteins or monoclonal antibodies, and they are held in reserve for severe refractory cases. Why all the caution?
2 main reasons: expense and prominent adverse effects. These agents bypass that broad chemical suppression we were just talking about and go straight for the specific inflammatory molecules themselves, like TNFi and IL-1.
But in doing so,
In doing so, they disrupt fundamental parts of the body's core defense system.
Let's start with the big one, the TNF-I inhibitors. If TNF-I is the key artillery commander in that inflammatory cycle, how do these biologicals actually neutralize it?
They're essentially cytokine-catching devices. They are either soluble receptors or monoclonal antibodies that are designed to bind directly to TNF molecules floating around in the bloodstream.
So they intercept the message?
They prevent it from ever attaching to cell receptors and delivering its pro-inflammatory message. This dramatically suppresses macrophage and T-cell function, and it leads to a much quicker response than the non-biological DRs. And importantly, they are superior at slowing those joint erosions.
The sources, though, are completely unequivocal about the resulting risk, and it connects directly to TNF's essential role in our defenses.
This is the massive trade-off. TNF is absolutely vital for the body to fight off certain types of chronic, slow-growing infections, particularly bacterial and what we call granulomatous infections.
Like tuberculosis.
Exactly like tuberculosis or certain fungal diseases. When you neutralize TNF, you greatly increase the patient's susceptibility to these opportunistic pathogens. All patients have to be screened for latent TB before they can even start these drugs.
That is a staggering risk profile. You're trading a guaranteed crippling joint disease for a serious chance of developing a catastrophic infection.
It forces a highly informed calculation. Let's look at the examples. We have etanercept. This is a recombinant fusion protein, basically a manufactured blend of a TNF receptor and part of a human antibody.
And how is it given?
It's given subcutaneously, so an injection under the skin. It acts as a decoy receptor, just soaking up any available TNFO.
And then you have the monoclonal antibodies, starting with infliximab.
Infliximab is a chimeric monoclonal antibody. Chimeric means it's part mouse, part human.
Okay.
It's administered via an intravenous infusion, which can often be associated with acute reactions, fever, chills, sometimes even bronchospasm.
And this one is almost always used with MTEX.
Yes, it's almost always combined with MTEX to enhance its efficacy and, just as importantly, to prevent the body from developing neutralizing antibodies against the mouse part of the drug.
And then adalimumab, which is the fully human antibody.
Adalimumab is a fully recombinant human monoclonal antibody, also given subcutaneously. Being fully human reduces some of that antibody formation risk compared to infliximab, but combining it with MTX is still the standard approach to maximize its impact.
So moving beyond TMET, we can look at other targeted biologicals. What about anakinra? It targets IL-1.
Anakinra is a recombinant IL-1 receptor antagonist, so it blocks IL-1, which is the other key cytokine. However, in practice, it demonstrates lower clinical efficacy compared to the TNF blockers.
So it's not used as much.
Consequently, it's used pretty sparingly, typically only in patients who have failed multiple other DRs.
Next is abatacept, which targets a really fundamental step in activating T cells.
Abatacept is fascinating. It tackles the T cell activation process itself. T cells, which are the core orchestrators of the immune response, usually need two signals to become fully activated.
Two signals.
Abatacept is a fusion protein that binds to molecules called CD80 and CD86, and in doing so, it effectively blocks the crucial second signal, the co-stimulation, that T cells require to get their full marching orders.
Wait, so if the T cell gets the first signal that there's a threat, but abatacept blocks that second signal, the T cell just, pauses?
It's put into a state of energy. It just kind of stalls out. It prevents the full activation and proliferation that's required to launch a massive destructive immune response.
And its use is highly restricted.
Oh, yeah. It's reserved for moderate to severe RA that hasn't responded even to combinations of MTX and a TNF antagonist. And here again, we have that crucial restriction. Due to the profound synergistic risk, abatacept should never be combined with TNF antagonists.
And finally, rituximab, which goes after the B lymphocytes directly.
Rituximab is a monoclonal antibody that was originally used in certain cancers. In MPRA, it's used to specifically deplete B lymphocytes, which are upstream drivers of the whole autoimmune process. It's given in combination with MTX, and it's strictly for active RA that is refractory to the combination of MTX plus a TNFA inhibitor.
This layering of treatments really shows just how resistant and aggressive advanced RA can be.
It's a constant escalation.
We have to include corticosteroids, glucocorticoids, in this discussion as well. They're potent, they're rapid-fire weapons, but they come with their own set of long-term costs.
They are the ultimate fast-acting relief valve. They are profoundly anti-inflammatory and immunosuppressant, and they afford prompt and marked symptomatic relief.
So they're used strategically.
Yes. They are added when you need potent action immediately while you're waiting for those slow-acting DMARDs to finally take hold.
So what defines the dilemma of long-term steroid use in RA?
The dilemma is profound. While they stop the immediate symptoms, they do not fundamentally arrest the underlying rheumatoid process. They might slow the rate of joint destruction a little, but the disease is still there.
And the long-term use is dangerous.
Prolonged systemic use carries serious, well-documented disadvantages, everything from bone thinning and weight gain to increased infection risk and Cushingoid features.
So how do physicians use them strategically to get the benefit without incurring the full cost?
There are three main strategies. First, low doses. We're talking 5 to 7.5 milligrams of prednisolone equivalent are used to supplement NSAIDs.
But the downside?
The unfortunate reality is that withdrawal is notoriously difficult. The patient often becomes steroid dependent because their symptoms just flare right back up the moment they try to stop.
So you're trading chronic inflammation for chronic steroid dependency?
It happens frequently. The second strategy is using high doses, but only for very short bursts. This is for when the RA is severe, systemic, or even organ-threatening. It buys crucial time while you're waiting for a DMARD to kick in.
And the third strategy is more localized.
Right. Intra-articular injection. If only one or a few joints are really flaring, you can inject the steroid directly for localized relief. But you shouldn't repeat that more often than every 3 or 4 months to protect the joint's integrity.
Okay, that gives us a really comprehensive picture of the RA pharmaceutical war. It's a relentless battle against the body's own immune system using these complex, high-risk agents.
Yes. Now, we are going to pivot completely. We're moving from an immune disorder to a purely metabolic disorder, gout.
A whole different battlefield.
So gout is fundamentally defined by hyperuricemia. What is that?
Hyperuricemia is simply an abnormally high concentration of plasma urate, which is the salt form of uric acid. Normal levels are generally between 2 and 6 milli-DL. The fundamental problem is that uric acid, which is a breakdown product of purine metabolism, has extremely low water solubility.
And when the levels get too high, what happens?
When the plasma levels exceed the saturation point, uric acid literally precipitates out of the solution and it deposits as these needle-sharp crystals. And they deposit primarily in joints, in the kidneys, and in the subcutaneous tissues, where they form those hard, chalky deposits that we call tophi.
So it's basically a disease of poor plumbing and bad solubility.
That's a perfect way to put it. And while most gout is primary, meaning the patient just genetically undersecretes uric acid hyperuricemia, can also be secondary to other conditions.
Can you elaborate on those secondary causes? I think that adds some crucial context. Certainly. Anything that causes enhanced nucleic acid metabolism can trigger it. For instance, in patients with leukemias or lymphomas, especially when they undergo chemotherapy or radiation.
Right, there's a lot of cell death.
There's a massive, rapid breakdown of cell nuclei. This huge cell turnover generates a surge of purines, which just overwhelms the body's ability to process and excrete the resulting uric acid.
So treating one serious condition can temporarily trigger the metabolic crisis of gout?
It absolutely can.
Oh.
And we also see drug-induced hyperuricemia. Certain common medications can interfere with the kidney's ability to excrete uric acid.
Which ones?
The prime examples are diuretics, specifically thiazides and furosemide, and even levodopa. These drugs can worsen or trigger gout flares in people who are already susceptible.
Now let's focus on the acute crisis. Acute gouty arthritis.
This is the hallmark attack. That sudden, explosively painful inflammation. Classically, it affects the metatarsophalangeal joint of the great toe, and it often wakes the patient up in the middle of the night.
And this needs immediate attention.
This immediate severe crisis requires aggressive, strong anti-inflammatory treatment. And here's the foundational rule that distinguishes gout treatment strategy. During an acute attack, you treat the inflammation. You absolutely do not attempt to lower the blood urate level yet.
So the immediate goal is firepower against the pain and inflammation, and the first line of defense is NSAIDs.
Yes. High doses of strong NSAIDs, naproxen, indomethacin, piroxicam given quickly and repeatedly. They are favored over the historic treatment, colchicine, mainly because they are just significantly better tolerated by the patient.
And some NSAIDs seem to have a more targeted effect against the specific mechanics of gouty inflammation.
They do. Naproxen and piroxicam are known specifically to inhibit the migration of leukocytes into that inflamed joint, which helps to short-circuit part of that self-perpetuating cycle.
And relief is pretty quick.
Relief usually begins within 12 to 24 hours. And crucially, after the intense inflammation subsides, the patient has to continue taking a lower dose of the NSAID for 3 to 4 weeks. This bridges the gap until the long-term uric acid control drugs can stabilize everything.
Okay, let's move to that historic specific treatment. Colchicine. The sources describe it as neither an analgesic nor an anti-inflammatory drug, yet it uniquely suppresses gouty inflammation. That sounds like pharmaceutical magic.
This is the quintessential aha moment in gout pharmacology.
Yeah.
Colchicine, which has been used since 1763, doesn't touch the pain pathways, and it doesn't affect uric acid synthesis or excretion at all.
So what does it do?
Instead, it targets the unique vicious cycle that gets initiated by the urate crystals themselves.
Okay, walk us through that vicious cycle and how colchicine interrupts it.
So when those sharp urate crystals precipitate in the joint, they are immediately engulfed by immune cells, especially granulocytes. This process is toxic to the cells, causing them to burst open and release powerful chemotactic factors.
Which call in reinforcements.
They call in more granulocytes, which in turn phagocytose more crystals, release more destructive enzymes, and, critically, they release a glycoprotein that lowers the local pH.
Which causes even more crystals to precipitate out.
Exactly. It's a self-reinforcing catastrophe, an exponentially worsening fire.
So how does colchicine act like a chemical firefighter?
Colchicine prevents the fire department, the granulocytes, from ever arriving at the scene. It inhibits their migration into the joint.
Oh, wow.
It achieves this by binding to a structural protein inside the cell called tubulin. Tubulin is vital for cell motility and for cell division mitosis. By disrupting tubulin, colchicine stops the movement of the inflammatory cells, and it also stops them from releasing those chemotactic factors that keep the cycle going.
And because it so specifically and dramatically stops the cycle, the response time is incredibly fast, right?
It is the fastest acting agent.
Okay.
It often achieves control in 6 to 12 hours. The response is so dramatic that a rapid resolution of symptoms after taking it can often be used as a diagnostic confirmation of gout.
But there's a high price tag of toxicity.
A very high price tag.
What are the dose-limiting side effects that have pushed it to a second-line option?
They're almost exclusively severe gastrointestinal effects. Nausea, vomiting, and frequently bloody diarrhea.
Why does that happen?
It happens because colchicine's mechanism of inhibiting tubulin disrupts mitosis cell division in all rapidly dividing cells. And the cells lining the gut mucosa are among the most rapidly dividing in the body. You essentially give the patient a severe case of gastroenteritis, which makes NSAIDs a much better tolerated first choice for most people.
And finally, we have corticosteroids for acute gout.
Yes, they are highly effective and rapid, comparable to colchicine in speed. But they're reserved for specific circumstances, mainly for patients who have contraindications to NSAIDs, like serious renal failure or a history of severe peptic ulcer disease.
And they can be given a couple of different ways.
Right, systematically, or if it's only 1 or 2 joints, you can do an intra-articular injection.
Okay, so once the fire is out, the acute attack is managed, we have to transition to the chronic state. You got persistent pain, stiffness, those visible tophi deposits, and the critical risk of urate stones forming in the kidney.
Correct. The goal now is long-term metabolic control. And we have to revisit that foundational caution now that we're talking about starting uric acid-lowering therapy.
Right. Why is it so crucial that these uric acid-lowering drugs are never started during an acute attack?
Because if you dramatically change the plasma urate level, it causes physical instability. The fluctuating urate levels favor the intermittent dissolving and then recrystallization of urate deposits within the joint tissues.
Which just starts the whole fire all over again.
It can precipitate a brand new, excruciating acute gout attack or severely worsen an existing one. That's why that NSAI or colchicine cover has to be in place for the first 1 to 2 months while you're slowly and safely bringing the uric acid levels down.
Okay, so let's get into the synthesis inhibitors. This seems to be the first choice for chronic gout.
It is. The most logical way to reduce high levels is to stop the body from making it in the first place.
Which brings us to allopurinol, the standard of care.
Allopurinol is the workhorse of chronic gout management. It works for pretty much all patient types, both overproducers and underexcretors, and it's essential for severe cases or those with confirmed kidney problems. It works by inhibiting the enzyme that creates uric acid, xanthine oxidase.
But the mechanism described in the source material is really intricate. It involves a competitive inhibitor and then its non-competitive metabolite. Let's break that down, because this seems to be where the genius of the drug lies.
It really is. The initial molecule, allopurinol itself, is a hypoxanthine analog, and it acts as a short-acting competitive inhibitor of xanthine oxidase. It fights for the enzyme's active site.
But that's not the whole story.
That's not the whole story. The true hero of this therapy is its major metabolite, which is called aloxanthine, or sometimes oxypurine.
And what makes aloxanthine the long-acting hero?
Well, aloxanthine has a much longer half-life, around 24 hours, so its effect lasts all day with just once daily dosing. And crucially, it is a non-competitive inhibitor of xanthine oxidase.
So it doesn't just compete for the active site?
No, it binds to the enzyme at a different location, and it changes the enzyme's shape, rendering it permanently inactive until the cell can make a new enzyme. This sustained non-competitive inhibition is what's primarily responsible for the long-term reduction in uric acid synthesis.
So by blocking the final step of the purine pathway, you reduce uric acid. What happens to the precursor compounds, hypoxanthine and xanthine?
The plasma concentration of uric acid goes down, and the concentrations of the precursors, hypoxanthine and xanthine, go up a little bit. But this is the second major benefit of the drug. Hypoxanthine and xanthine are significantly more soluble than uric acid.
Ah, so you avoid the crystallization problem.
Exactly. Instead of forming insoluble crystalline uric acid, the body just excretes these three oxypurines, and crystallization in the joints and, more importantly, in the kidneys is avoided.
As with MTX, allopurinol has critical drug interactions, particularly with immunosuppressants.
This is a life-or-death interaction. Allopurinol strongly inhibits the degradation of immunosuppressant drugs like 6-mercaptopurine and azathioprine. If a patient is on both, the dose of the immunosuppressant must be reduced dramatically. We're talking to about 1/3 of the normal dose, or the patient risks severe, potentially fatal bone marrow depression.
Good to know. And now, what about the newer alternative, febuxostat?
Febuxostat is a non-purine xanthine oxidase inhibitor, so it's chemically distinct from allopurinol. It's considered equally, or sometimes even more, effective at lowering uric acid levels.
But it has its own risk profile.
It does. Most importantly, a significant risk of liver damage, which requires regular monitoring of liver function.
And the combination restrictions are just as tight as allopurinol.
Absolutely. Febuxostat should never be combined with allopurinol. And because it does the same essential job of blocking xanthine oxidase, it is contraindicated in patients who are receiving mercaptopurine, azathioprine, or even theophylline, again because of the potential for severely toxic drug accumulations.
Okay, so if you can't stop the body from making uric acid, the other option is to force the kidneys to flush it out. This is the role of the uricosuric drugs. How do they work at the renal level?
These drugs interfere with the kidney's built-in recycling system. Specifically, they inhibit the active reabsorption of uric acid from the renal tubules back into the blood.
There's a specific transporter for that, right?
There is. Uric acid is reabsorbed via a transporter called URAT1. By blocking URAT1, these drugs prevent the kidney from vacuuming the uric acid back into the blood, thus promoting massive excretion and lowering blood levels.
And probenecid is the classic example here.
It is. And it has a great backstory. Probenecid was first developed to prolong the half-life of penicillin during World War II, when penicillin was scarce.
How did it do that?
It works by blocking the active tubular secretion of penicillin, keeping it in the body longer. In gout, that same general mechanism of blocking organic acid transport prevents the reabsorption of uric acid. It's a second-line or an adjuvant drug, and it's generally well tolerated.
What are the specific limitations that keep it behind allopurinol as a first choice?
Two major limitations. First, it is essentially ineffective if the patient already has renal insufficiency. The kidneys have to be functioning reasonably well for it to work.
And the second?
Second, it is strictly contraindicated in patients with a history of kidney stones. If you suddenly force massive amounts of insoluble uric acid into the urine, you create a high risk of precipitation and stone formation. These patients have to be instructed to drink copious amounts of water, at least 2 to 3 liters a day, to avoid that.
And there are other less common uricosurics as well.
Yes, sulfenpyrazone, but it's rarely used now due to more gastric irritation. And there's lesinurad, a newer drug that's approved specifically for its mechanism of inhibiting URAT1.
So, for those rare refractory cases that simply cannot get control with inhibitors or uricosurics, we move to the final reserve, pegloticase. This employs an enzyme that humans naturally lack.
This is truly a last resort strategy. Pegloticase is a recombinant form of the enzyme uricase.
Uricase.
Uricase is an enzyme that's present in most other mammals, but humans lost it through evolution. And what uricase does is it oxidizes uric acid into allantoin.
And allantoin is different how?
Allantoin is a compound that is highly soluble and very easily excreted by the kidney. So it bypasses the solubility problem entirely by chemically transforming uric acid into something harmless.
But the risks associated with this unique mechanism are high.
The risks are severe. Because you're introducing a non-human enzyme, pegloticase is highly immunogenic. It carries a high risk of infusion reactions, including anaphylaxis.
So it has to be given in a hospital setting.
It must only be administered in a clinical setting where the emergency management of anaphylaxis is immediately available. And on top of that, over time, antibody formation against pegloticase means that many patients eventually lose their response to the drug.
What an incredible comparison. We have spent this entire deep dive detailing two completely different pharmaceutical landscapes, even though the resulting symptom-crippling joint disease is the same.
The synthesis is just so clear, isn't it? Rheumatoid arthritis demands a systemic, calculated chemical suppression of the immune system. We use these complex, slow-acting agents like methotrexate or highly targeted biologicals that stop the inflammatory message mid-transmission.
But we have to accept the risk of serious infection.
It's a high-stakes chronic compromise.
And gout, on the other hand, requires that two-step metabolic strategy. First, an immediate strike against the inflammation using NAIDs or that mitotic inhibitor, colchicine.
Right, and that's followed by a long-term strategy to manage the plumbing, either blocking the production of uric acid with xanthine oxidase inhibitors like allopurinol and its metabolite aloxanthine,
Or increasing excretion with uricosurics like probenecid.
we've really seen how both the body's natural immunological drive and its basic metabolic waste management systems can lead to profoundly crippling disease. And they require these targeted chemical interventions that always involve a trade-off between efficacy and toxicity. This field is just a constant balancing act.
And here's where it gets really interesting as we look to the future. We've seen this long history of pharmaceutical repurposing, right?
Yeah.
Methotrexate was a cancer agent. Hydroxychloroquine was an anti-malarial.
Allopurinol was synthesized as a potential purine antimetabolite.
Exactly. So given the highly specific, high-risk nature of the newest biological agents, like the TNF inhibitors and that exotic life-saving pegloticase, what will the next generation of joint disease treatments even look like?
That is the question. Will we see even finer refinements of targeted signaling pathways? Perhaps moving toward more focused, safer JAK inhibition that blocks specific cytokine pathways without inducing that global immunocompromise. Or will the breakthrough come from entirely new approaches to managing the body's fundamental metabolic and immune waste systems? Finding the next less toxic allopurinol that corrects the underlying imbalance without necessitating chronic high-risk surveillance.
That distinction, hyper-specific immune targeting versus systemic metabolic correction, that is the defining challenge of pharmaceutical research in this area, something for you to consider as you process this deep dive.